Welcome back to the Evolution of Dental podcast, brought to you by Evolution Dental Science. Today we're joined by a pioneer of digital dentistry, one of the first 8 to have adopted the iTero system in North America, the doctor on the forefront of the new ART, Advanced Restorative Treatment program from iTero. Hello, Dr. Glassman. How are you today?
I'm doing great, Robert. It's great to be here. I'm really excited with the partnership I've had with Evolution Dental Science for almost 2 years right now. So it's been great. Done some remarkable cases, changing people's lives every day. So this is what I live for.
Excellent. How would you say this has shifted from when you first brought the iTero into your practice in 2008?
Was actually, believe it or not, 2006.
2006?
Yes, 2006. As you said correctly, I was one of the original 8. Conversation. I went out in my laboratory. They thought it would not be a great fit in my office. They were looking for more of a bread and butter, a lot of volume crowns and stuff. And I was more comprehensive aesthetic. And then one of the VPs of Cadent, which that was the company's name before it was iTero, said, hey, let's go Dr. Glassman do it. And so I got involved with it. Back then, it would take maybe for a single crown about 6 minutes, which today is probably 30, 40 seconds with the new technology. So it was groundbreaking. We did a double-blind study comparing the crown scanned with the Cadent iTero unit back then, as well as conventional taking a PBS impression, and something that was like 2-to-1 or 3-to-1 preferred the scan crowns in terms of fit, contact, and occlusion.
3-to-1 is hard to argue with. And so you moved from using it for restorative dentistry into ortho.
That's also very interesting story. At the time, one of my patients, pretty high up on the Invisalign advisory board or corporate ladder, so to speak, and he was also a patient. And one day he comes in and he's asking me about the scanner, because I have been to all the convention shows, the Great New York every year, trying to get the two companies to work together. And I hear from a line, not ready yet. We need to get more roots. One day he comes in and says, what do you think of the technology? I said, well, I love the technology. I'm not 100% of the company. I think company needs a little bit more guidance. And a week later, a line, I think, paid $180, $190 million for the technology. So to bring it into the ortho world, and then it became all over. It started to expand. And the big change was going from the older units to the elements, which had more of that continuous scanning at that point. And it was really a game, but because they realized that the scanned aligners fit better. If they fit better, means the case is going to finish faster.
Absolutely. And so how did that influence the way you practice dentistry?
Well, as I got more involved with doing clear aligners and having some backgrounds, I started to realize that orthodontics was the foundation for all restorative and paleo. We can be so much more effective and so much more or less invasive by putting the teeth in their proper position, putting crowns over the roots, looking at everything. And then when the restorative would fall in place, which a lot of these cases would have worn enamel or chipped enamel, we could sometimes just finish the case with direct bonding resin. And even those cases that required a laboratory, typically cases that may have undersized upper laterals. By using the ortho and leaving space, we can do our veneers. The case will look better. All these, plus the cases that, great learning experience. I had an associate came in and patient came in and broke a central incisor. And so what did he do? Like trained in dental school, he treats the symptom and the problem without looking at the cause. So he ended up doing a root canal post and crown on a patient that had a malocclusion deep bite, only to find out in 3 months the tooth broke and needed an implant. And I went back and tried to educate him. I said, you set the scale against you by putting your case in something that was not lined up for it. And now the patient has to go through an extraction. It would have been better if you would have provisionalized him, gotten back, correct the deep bite, do the occlusion, and then finish the crown. So really, this type of thinking has really revolutionized the way I see patients. I look at people through not just one set of glasses. This is my restorative glasses, and this is my ortho glasses. I look at them as both the ortho-resto glasses. How do we do it? And now, since Align has grown, not just be a company that made Invisalign and working with iTero scanners, but a complete platform. And the purchase of exocad 5, 6, 7 years ago, the integration of those is really what separates it from every other company there. We have now a platform, and we can bring aligners in many different ways. The doctor can recommend it, but also my CAD designers, my partners at Evolution Science, can look at this and recommend to their doctors, doc, if you would just rotate these 2 teeth and let me show you my restoration, how much less enamel you'd have to remove, or maybe we can even do non-prep cases with it. And those cases will hold up, look better from it. So you're directing it both from not just the doctors, but the CAD designers that are working these cases every day.
Excellent. So a more comprehensive approach then, a more partnered approach with the laboratory.
Correct. And you know what? You may get away, in your early years doing dentistry that maybe you hope and a prayer that it'll last. But if you're practicing as long as I am, in this case, 41 years, you kind of see the areas that you miss out. All of a sudden you see, hey, this case I treated right. It's holding up 21 years, 25 years, 30 years, right? As opposed to the case I just showed you, the associate where the tooth broke in 3 months. So yeah, it really is less invasive, and the patients appreciate it because ultimately they will spend less money over a lifetime on their dentistry.
That's excellent. And so as far as I understand, you have a sort of a facially driven approach when it comes to analyzing the treatment for a patient as well as the aesthetics of a case?
That's correct. Big influence for me in my education were both John Coyce and Frank Spear, and they talked about facially driven treatment planning as opposed to, say, articulator, where we have models and we have no face behind it. So typically when a patient comes into practice, we will take one photo on everybody, even if it's the 60-year-old that just has hygiene. We want that wide smile photo with the teeth slightly separated so I could see the lower incisal edges. And we'll use some of the Align tools. That's the thing that I think a lot of people that are into digital dentistry don't really understand it. There are a lot of scanners out there. There are other software programs besides exocad, but this is really the only ortho-resto out there. So when I can show a patient a preview with their face of where the teeth should be right there, they're more likely to say, let me hear more about this. Let me see what is forward. So that's usually the starting point. And they in some cases, don't need aligners. Maybe it's an all-on-X case or a denture case. Then we translate our photos to the typical ones we require for exocad, which are the full face retracted, teeth closed, and then the full face smiling. That with a intraoral scanner, working with exocad CAD designers, I could start to look at every aspect of the facial, see if a tooth has been chipped off, if the gingival margins don't look right, they have a gummy smile, and we can start to plan it. In some cases, may need ortho going backwards. Some may need osseous crown lengthening. So now I can communicate with my periodontist by bringing my CBCT into the facial planning, working with that and say, where do we want to end our gingival margin? Where do we want to end our incisal edge? We can show a patient a preview, what this is going to look like using these tools, getting them to say yes. But when they say yes, we now have to plan the case. And the case all starts with these facially driven. And then we have the tools. In this case, I just mentioned to you, we would have printed up a surgical guide for the periodontist. But I know where the ultimate incisal edge is going to be because I already have that together. So all of these platform tools working with it. And then if we're doing same-day dentistry, that's even better because I could have a patient in the chair. Say we're doing our all-on-X case. We could scan them. And then we already have our digital wax up from it. We adopt that to either our scan bodies or our preps if we're doing full cases. And now the laboratory can send me the design that has been adapted to those preps, and I could print them in the office with my sprint ray. And so the patient can get a lab quality process in the same day, where in the older days, in the analog days, we'd have to take our PBS impressions, beg our laboratory to do a quick turnaround, which is typically 4 or 5 days, maybe later, and hoping that everything fits well, looks well, and oftentimes they did.
And so one of these tools that you're referring to, I'm assuming, is the exocad True Smile videos and exocad Smile Creator, perhaps?
Yes, those are excellent tools. We use them all today. They're available on the exocad platform, but they're also available on the iTero. Now, where we could do a Smile Architect, we could do it's called an Outcome Simulator Pro with that wide smile photo, the scan. Then I'll have 2 simulations. I'll have one with a ortho only and one with an ortho-restorative case. And that would be depending on how much teeth we have. We can go back and forth. And having that right here eliminates these mock-ups that we lab has to do, and we have to spend money for it, and we have to wait, spend time. It's done visually. We also have a smile video, which is very similar. So we have to think about what is our purpose? My first purpose is getting the patient to say yes. Once I get them to say yes to treatment, the next purpose is finalizing the design. So with the True Smile video on exocad, I can try in a variety of different libraries of smiles and find the one that both, but all 3 of us, the laboratory partner, the clinician, and the patient all agrees is the best. And then from that, we can be really predictable on the outcome. We can print a prototype from those cases, let them walk around it, modify that, but it all starts. It's, again, the analog days. What did we used to do? Bring me 3 photos, and they would bring you photos from their fashion magazine, and each smile would look completely different. They happen to love the person who was attractive in it, but they're not looking at them. Now they see it in their face, and they don't have to wait for a mock-up to go right on their mouth, and listen.
And it's in office, and it's an actionable CAD file. You can actually print these. It's not just Photoshop.
Exactly. It's right in the office. I could go ahead and do this, print this up on the mouth. Once we have it together, they could do a trial. They can make it part of the provisional. There's so many different ways we can use these tools.
Are there any tools upcoming that you're really excited to get into?
Well, I think that the next phase for me are 2 of them. And they've been around there, but they're not under one platform. Think about this with our mobile phones. And typically people are Apple or they're on Droid. And so they have all these different tools that work them. I think that's going to see more and more of that. Now, when we do the exocad, or if we're using the iTero Smile Architect, typically the photos are only in 2-dimensional.
Right. You're doing 3D face scans in your office, aren't you?
We're doing 3D face scans. So let me explain the difference in the value of that. When we merge those things for typical exocad, we only could see the patient's face directly on it. It's like a cardboard cutout. But people want to see what their profile will look like. In certain cases, we want to see the soft tissue changes from start and even before. Right now, we can take 3D facial scans in the beginning, at the end, but we're not quite there with the simulation. What am I talking about? If somebody has flared buccal teeth, the profile has changed, right? I like to show them not just where their teeth are, but where their lips are going to fall through. If we're opening people's vertical dimension and they're overclosed, I like them to see what that's going to look like. Now, the cases that I'm going to show later on, we've changed the verticals, we changed the profiles, but I had no tool really to predictably plan the case, or even if the patient wanted to use that before they commit treatment, that would have been helpful. I think that's the next thing. Again, there are a bunch of scanners out there, and I tell doctors the difference between the $20,000 scanner and the $200 scanner is not that much. Invisalign has one when they take records, but it's only on the ortho side, not on the ortho-resto side. as of yet. I'm sure it will be. I use a inexpensive one called Clone, QLONE, where I typically take those photos. I'll probably sometimes take 3 facial scans, one with the retracted smile, one with the patient smiling without retractors, and one repose, because I want to see that soft tissue lip and everything. So that's something I think is coming out. I'm really excited about that. I'm also excited about using some of the jaw motion. A lot of the times when we do our cases to our CAD designers, where we have a static way to take the bite. They just bite down in one position. Now, Aligned has up their game in the last 6 months, so we can take multiple bites. We can take, for restorative, we could take or for dentures or full arch cases, we could take a protrusive, a right lateral, left lateral, retrusive, open bite. And so the CAD designers can put all that together, but it's still a series of static movements. There are other companies like Modular out there that will track dynamic movements of jaws, which they could put into it. Again, a lot of these things are for the elite practices that are focused on them because they're quite expensive. If we can take something and bring it to our mobile phone and affordable, which I gave you the example of the 3D facial scans, the next level is doing the jaw motion with your iPhone or your Droid and taking that file and having it to be integrated with the with exocad CAD designer. So we get a true dynamic which teeth are dentures. Really important. Talk about implants or dentures. We want to make sure those forces are balanced.
So, in your opinion, the next phase is to and not just take multiple pictures from multiple angles, but multiple facial scans in different situations, so you can incorporate that simulation. Is that right?
Correct.
That sounds pretty awesome. I'm sure the coming AI innovations will tie that together pretty well too. Especially seeing what they're able to do now with the video on a 2-dimensional representation.
Yeah, they can see the outcome from it. We've all been there, and I've been there in my 41 years, where we do a wax up on an articulator, and the patient looks at it and they kind of scratch your head. It looks pretty good to me. I don't know how it's going to be in my face. Maybe we even put it on the face, but they're not going home for it. And then we go ahead and give them something, and they said, that's really not what I was looking for. That's really the stressful part of dentistry, not understanding the vision of your patient and having these tools to make sure so easy to do another design, click of a button, print up a no one before we go to it. It's actually when we have to do our final restorations that are milled and layered and custom stained. That's a lot of labor and time inclusive. And once they're bonded to the teeth, we can't take them off. We have to drill them off. Nobody likes taking off existing dental work. I can tell you that.
So, are you doing any 3D printed try-ins, like Snap-on smiles, to demonstrate to the patients what it's going to actually look like in their mouth in the practice, or are you mainly relying on the video and 2-dimensional representations?
I'm mainly doing the digital tools right here because I have that done immediately. I can show the patient a ortho only simulation. I could show them an ortho-resto. Here's another interesting story I had. I had a patient that had Invisalign done 15 years ago. She wasn't great about wearing a line. She comes back, very attractive lady. And then so we did the ortho only, and then we did the resto, and I would toggle back and forth, just showing ortho, just showing resto. In the software, not only did it just do 4 veneers on the upper incisors, but it also did a little gingivectomy. And she said to me, I want that treatment. So it's just a simple thing. That treatment added on another $9,000 to the treatment plan. And it's just going to fix that. But most doctors are not taking the time. Now, you asked about the mock-up of smiles. Yes, not as much. If somebody I find is that really particular patient, or it's something that I want to walk, because we've been working with the non-prep printed veneers. One thing about printing, the materials are getting better, more highly filled with ceramics, so they hold up better and they look great. So I've done that on a few cases with it. But again, that requires labor and time and a bit of a gamble.
A little bit of materials. Yeah.
A little materials. But I'm saying if the patient is not committed, we may have done this. I said, I don't really think you need that to get patient to commit. I think it's a good thing in terms of the planning. Before we're doing that, if we have the patient that is really particularly want to see it and work it up before we do it, that's a way to go.
That makes sense. That makes good sense. And not to mention, it helps you meet the patient at their level of expectation so that, like you were saying before, all three of us, you, the lab, and the patient can come together on a particular outcome and be happy with it at the end, right?
Correct. So say, for example, we show the patient's really wide smile and we plan to do 10 restorations on the upper, right? And they're a little in between. Let me see what it looks like with only 8 restorations or 6 or 4. So very quickly, we can eliminate those other sides and show the patient what it would look like so they could find the best one that will match them. Obviously, when we're talking about those comprehensive cases, budget comes into, and you'd be surprised. I'm still surprised, 41 years. Some people coming in you think can afford it, won't do it. And other people you think that, I had a guy once that came in, I swear to God, he looked like he was homeless. And most doctors wouldn't give him the time of day. We found out later that he had a huge lawsuit against the city of New York. He was hit by a bus and had a big settlement. And the first thing that he wanted to do was fix his teeth. And so he came in there, and one of the first upper lower full arch implant cases I did about 12 years ago, and case came out spectacular.
That's fantastic. Are there any such cases that you want to look at here today that we have visuals for?
Yeah. I think I like to show the one of the first case. It's a very interesting one. So here's my workflow for exams. And I think technology is making us rethink how we do examinations. Here we start with taking that wide, small photo, as I said. And then I am now doing my intraoral scan. I am encouraging the patient to look at that intraoral scan and point out things they think would be interesting. And the analogy I like to make it is if you've ever taken a elementary school or middle school person to a museum, they have all these exhibits, but a lot of the exhibits are touchscreen, and there's information that are there, and it gets the young student's mind to want to ask more questions and want to learn more. The same thing here. Once they see their scan, and they relate much more to a digital scan than they do x-rays or the mirror in the mouth, and they start to ask me questions. And I say, what do you think? You think things are healthy? Are there anything of concern? And so they may point out the inflamed tissue. They may point out the chipped tooth or the black filling on a tooth. So we're encouraging that. We're going to, we use our little magnifying glass to blow them up. And we have something that is in the scan when we send the scan to the cloud. Typically, the mode is we scan the patient, we download a view it, and then we put it to the cloud. We have these tools, and it's called the Oral Health Suite. What separates the Oral Health Suite is they use terms that the patient will understand, like gum health, tooth health, alignment, and bite. And every area we are concerned, we can screenshot that patient. We also have a tool called near infrared imaging. Is when we go to tooth health, we can pick up interproximal caries before they show up on x-rays. So we screenshot areas of concern. We can go into their alignment and see if they have too much contact on the facially of the lower incisors, and is that causing shipping or wear? Do we have abstractions? All those information from them. So we're looking at it, breaking it down to all those things. Periol, we can now look at gingival margins. We can look at tooth restorations. Often I'll show them in a stone model. Stone model will pick up fractured teeth and fractured things before we show it up. On the magnifying glass, we can look at the margins of fillings on it to see if there's any leakage. And in these areas, we're going to concern. At the very end, we're going to go and press the button for Outcome Simulator Pro. And while that's showing, we'll look at the original photo, the photo that has the ortho correction, and the full face photo that has ortho and resto. Now, again, if the patient doesn't really need ortho, 25, 30% of the population, then we could just show them the restorative. That's why I like this method. It's right there.
It's right there.
It's right there. I could do, if I think the patient would be a cosmetic value, I'll add that 30-second video. The video is the same on the Align platform that I use them to invoke something that they're interested, emotion, passion. I'll ask them where they spend their summer vacation. Or if it's a woman getting married, I'll talk about their wedding. Or if somebody who is a big fan of a sports team, like I know the Evolution are big Buffalo Bills fans, I'll ask about how that game was. And all of a sudden you'll see the smile and the personality and teeth. And then they see it side by side with the AI version of it, ortho-resto, and they go, oh my God, this is amazing. So this all lands to it. Now, before they leave, all the screenshots and all the copies I have, I will share their report with them by a QR code. Everything I've taken in that visit, every video, every outcome simulator is incorporated in it, and they take it on their mobile phone. I will then escort the patient to the front desk, and then I will tell them, so-and-so, we spoke about these areas. We have some period issues. We have some restorative alignment issues, and we're going to finish this with some veneers on the case. And we have everything mapped to them, and they have everything in their phone. We focus on problem, consequence, solution. So when they go back to their significant other or their parent, it's not just a line item price of what it's going to cost. They're showing them why they need it and what it's going to look like. So that will increase acceptance,
so to speak.
Exactly. At least 35% increase in case acceptance by doing that.
35% increase. That's notable.
And
wow.
It's amazing. Okay. That's what I want to tell doctors. You don't have to have always the volume 50. You need the right patient to come in, and the real clear skill is getting the asymptomatic patients to realize they have situations and to move forward. If you master that, you'll be doing way more close to your potential.
So you'd say that you'd use these tools quite a bit to diagnose the asymptomatic patients and really illustrate to them seeing is believing. Is that what I'm hearing correctly?
Seeing is believing. They see it. They want to see it. They're visual. We do it on all new patients, emergency patients, unless they're in so much pain I can't get a scan of them. And hygiene. Hygiene we'll do once a year. And the good thing about this scan, if say they don't say yes this year, we'll scan them again the following year, and then we can overlap the scan with a tool called time lapse. And time lapse will show me if the situation is getting worse. I had a patient from Britain. They would say Britain's teeth, a lot of crowding. Took him 10 years before he realized that the case was getting worse, and he finally decided to go through Invasive.
Right, because if you have a year or 2 or 10, Lord, between the two scans and images, it's pretty easy to illustrate the difference. Whereas if you're seeing your face in the mirror every day, the gradual change is, it's sort of like watching grass grow. It's like one day it's not there, and the next day it is, and somewhere in between that change occurred, but it's hard to illustrate, especially when, let's be honest, regular patients, their focus isn't teeth like you or I.
Correct. I make a joke. I say it's like my hairline. I look at pictures from 15 years ago. Jesus, where was what happened to that full head of hair? It's, it happens. It's not linear. It happens over time. It's just like the patient's enamel. And I say that to doctors. My big topic on this last presentation, which will refer to this case here, is had we been complicit with our patient's enamel wearing away?
It's a very pointed question, and it's true.
Yeah. They go to, hygienists will say, oh, it's hard toothbrush, aggressive lunch grinding, but there are other factors on there. There's acids in the diet. There's even, a lot of people are antidepressives today. A lot of those patients will grind and clench their teeth, their jaw motion, and wear them down faster. Obviously, there are eating disorders that can contribute it, bulimia, anorexia. Some of the kids that all they do is suck on iced tea with lemon all day, or frappuccinos between the acid and the sugar. These are all things that can do that. But it's all of a sudden the patient, if you're ignoring it, this is going to happen to you. As the patient will say, Doc, I've been a patient here for 20 years. I come in every year. You tell me my gums, my teeth are fine. What happened to my teeth? Why are they so short? Why are they wearing down? Why can't I see yellow underneath it? And it's because we're missing these signs and symptoms of tooth wear.
Absolutely. And so this other slide that you wanted to look at here, this other patient.
Yes. So this is a really interesting case. She came in here for a second opinion. And that was her full face photo. I would love to show her teeth after smiling, but she had a provisional on the lower right side from 29 to 31. And the dentist who was treating her wanted to go to the periodontist to do a crown lengthening. Of course, the teeth was so short. Just think about it, okay? The teeth was so short, but the doctor cut down the incisal edge, the occlusal edges, so he can get a crown on it. Does that make any sense to you? We want to make the teeth up. So I look through her mouth. We're measuring central incisors that are 7, 8 millimeters. They should be 10 or 11. And I show her wear throughout the mouth, and I show counteracts, and we start to do some of the digital tools. And I said to her, and you could look at her big maxilars, she's grinding and tension. And so I said, I really want to replace the lost enamel and give you back the protective chewing motions so it will protect these teeth from continuing to wear, and you don't have to go through a crown lengthening. That's a good news for you. So she was interested. Can we show the next slide?
Absolutely.
I'll go through this and I'll make a diagnosis both on an orthodontic checklist and areas I want to approve. And then if you go to the next one, I think I have one in black and white. That's the functional one. And I start to see where the contacts are and things that we want to change. So that's typically my exercise, not so much through the patient. This is more, I got the patient to say yes. So here is the wild smile photo. And we see with the outcome simulator with Smile Architect, again, we could have done aligners. There's only one tooth. I think number 7 was slightly overlapped, but because the tooth needed a crown anyway, we eliminated the ortho part of this, and I just showed her the restorative. And she looks at this and she says, "Wow, this is pretty cool, right?" And let me see more. So let's go to the next one. And now you have the video of that. I don't know if you can play it. She's talking, and now the upper and lower teeth have been restored. And at the very end, the final outcome looks very similar to the AI simulation through this. So she's seeing all this stuff on the glasses. We've opened up her vertical a little bit, but that's still the area that's missing. We need to bring that shows the soft tissue changes of opening the vertical compared to, and the profile once the soft tissue things are made. So that was a Smile video that is on the iTero unit. If you don't have an iTero scanner, which again, I'm highly recommended, but you can use this with the True Video on the exocad. So you would send your laboratory these photos and the video, and they can do the simulation with it. They can actually even do more with that. I can show them the opening of the vertical. In this case, we end up opening her by 5 millimeters. I could simulate that better with the True Smile video than I can with the Outcome Simulator Pro. But the point is that these facial scans will show the profile from every angle with it. And so when we do our design, we can show the design with the recommended treatment plans for it. So this is typically I take with the clone. It takes me about 60 seconds to capture each one. And then each one we export via Dropbox link to our CAD designer. So we can merge the 360 facial scan, and we can bring that into the
design software. Yeah,
exactly. All those things together, we have it. And let's continue on. I think I brought some other photos. Again, this is my external lab partner. Now the patient has said yes. We're now into the planning case, which means we have to design the case with the right provisionals. So we send all these tools to our exocad designer. The great thing about using when we submit cases for same-day dentistry, they're able to bring that scanned folder right into their DB designer. They don't have to They don't have to download files and upload files. It goes right into it. So here's I think this was done. This is done by Johnny Exocad, Johnny Jackson of your team, but he's now using the design. We have it all done together where we see the 360 facial scan with the intraoral scan on it. And if I was doing any osseous crown lengthening or implants, I would also put the CBCT in. So now we're planning it. We originally decided to open the bite 3.5 millimeters so that we have enough interarch occlusal. And then the preparations, especially in the molars, I was just flattening them. I wasn't taking them off, flattening them, going around there. So truly minimally invasive. The provisionals were made after we agreed on our digital wax up. We could scan the patient, and then they could send me back the file so I could print the provisionals right in the office. So the uppers, originally she agreed on it because the budget, we're going to do the full arch upper and just the posterior teeth on the lower. And then once we finished the upper and lower arch, she didn't love the lower 6 lower incisors. So I said, I just came back from this new course on 3D printed veneers. I'm going to give you the deal of a lifetime. Let me just do non-prep printed veneers on the lowers just to make up a difference in the occlusal. Because when we were doing the final lower restorations, we decided to open up another millimeter for millimeter and a half for a total of 5 millimeters because I wanted to make sure I had enough clearance on the molars. So when that was finished, we still had space between the lower anteriors, which we now did our 3D printed veneers, and you could show you how the case turned out.
Wow.
That's the first stage. This is the new vertical dimension at 3.5. The uppers are done. Okay, so this is the final scan of the provisionals. They have the provisionals. They're able to merge them so I can get that done. With the iTero, to scan a full arch like that takes you less than 5 minutes. It's a continuous wave scan. And if I don't like the particular scan up, I'll go back and just erase that one prep. Maybe I'll do a little bit of tissue retraction. Maybe I'll make it smoother and go back to it. It just makes the dentistry so much less stressful. And we're able to get ideal results. And because it's all digital, there's never an issue with the bite. The bite goes in typically with either no adjustments or minimal adjustments on the occlusal. So this was done. Let's go to the next area. Now, this is the final case after we finished the lower teeth against the upper finals, another millimeter. So total of about 4.5, I think. And you can look at her face. She looks terrific.
Oh, that's joy you can't hide. Look at that. What a transformation.
Yeah, and we can see the comparison as you go along. Let's go another slide there. There is her comparison original. You can see her lower third of the face is better. Oh, she looks younger. She's happier. This is the comparison video I took originally with the iTero Outcome Smile video and the final video talking. And they look really comparable to what we planned and we delivered it. And again, efficiency. There's none of this stuff going back to the laboratory. The bite is off, nothing. Everything is planned. And as I say, my favorite line is if you fail to plan, you plan to fail. And so really, really is the case. And I could have done it without my exocad partners at Evolution Science, really. They make it so easy to work with. And when I want to do same-day dentistry, I just schedule in advance. I give them an update how I'm doing for time. They take my scan with my original plan and then modify it. I get the STL files and something like this, I would print probably like in an hour in the office, which if I'm doing it analog in the mouth, I probably would spend an hour anyway and they wouldn't come out as good.
That's excellent. That is unbelievable. How does that relate to the advancements you're working on with the ART, Advanced Restorative Treatment Program that they're looking at debuting soon?
We are working with our trial case. We have a great volunteer, another Jackson from here called Josh, who has severe wear all of his teeth. He's missing his molars, but we want to also with the ART, which is funny because he coming from the restorative files, and the ART would say, Doc, we're changing your plan, with Invisalign. We want to move them in this direction because we know what the final restoration. We do this right. All you need to do is take 0.1 millimeters off the facial surfaces, and then we will give them a restoration. And I think there is, I said earlier, going back to my message, a lot of restorative doctors are either focused on the restorative / perio. A lot of them are into either cosmetics like veneers or on implants, and they don't understand the value of tooth movement. By having our designers recommend to them about tooth movement, a simple thing, must have said in the last 2 years, I must have 4 cases where we moved teeth to put implants on upper laterals that were generally missing, but we don't have the space. But now, having the ability to include CBCT in art and tooth movement in art, we can plan exactly how much we have to move them. We can bring into our implant planning software so we know which implant we're going to put in there. We have it all ready to go. So move the teeth first, place the implant, and then we'll provisionalize them. And how do we do that? We will reserve it with our exocad partners. We'll place our scan body in. We'll have pre-bought our tie base in the office. And so we'll design it. We'll print it up in about 30 minutes. We'll cement it onto the tie base. And now they get a lab quality restoration while the tissue's healing that they could wear for 6 weeks while it's healing before we finish the restoration. If I were to do this analog way, first of all, maybe I would do 1 tooth. I'm doing multiple teeth. I could never do it.
No.
And they would also not look great. They would break. I get frustrated. I couldn't get the pull out. So it's so much better done digitally through the use of the software.
How would you recommend other doctors approach entering? Because I think, like you're right, I think a lot of doctors don't really appreciate how much ortho really plays into the comprehensive treatment. How would you recommend they tiptoe into that?
Listen, there are a lot of clear aligners out there. Obviously, I'm biased towards that, but I've also, whatever gets you to the final setup, if you're going to use a competitor line, that's okay. If you use a different scanner, that's okay. But a lot of doctors, and some that are very successful and very talented, are just stubborn, right? They think the ortho is something that is an extra step, 3 months, 4 months, 6 months. They're not looking. And to me, if you're cutting down teeth, there's the famous line, right? If every tool you have if the only tool you have is a hammer, everything looks like a nail.
Everything's a nail.
Yeah, everything's a nail to them. And those cases will be more invasive, which means more likelihood of endo and fracture and everything. Now, maybe you don't care, which I think more than not, most dentists do care. They have to be shown that it's easier to do that. I mean, especially if you're doing, not every implant case you're doing is full arch. So if you're threading implants between natural teeth, it's your best friend. You want that path of insertion. You want to get rid of the malocclusion. You don't want to put an implant on a deep bite that's going to put pressure and make the implant fail. You really need to know that. So I'm hoping designers like you will be doing that. Or what I'm doing, I decided to take my own way to do this because I've been frustrated with some of the CEA. I've been in continuing education for 21 years as a faculty member line. I'm doing my own program calling Glassman Academy of Ortho-Resto, trying to bring those doctors into the digital world and understanding the value of all these things, same-day dentistry. And you don't have to come in and become a master of exocad. We'll give you the tools so that you know how it works, and if that's what you want to do it. But to use these tools, iTero on the platform has an exocad Lite available to them. It's not facially driven.
Sweet. Yeah.
Exactly. But if somebody comes in without a bridge, I can design a bridge on those preps and print something in 20, 30 minutes from them. They can go out. So there's a lot I could do with designs. I could do mock-ups from them. I could do occlusal guards. I could do crowns and Some of the restorations coming out of Midas are 70% filled. They're 80 approved for final restorations. Insurance will pay for that. If you're comfortable doing that, my feeling is that 3D printing will replace all milling in the future.
I agree.
So you'll be doing same day dentistry with that. So I would say my course is going to help you master iTero Design Suite, understand art, how to use exocad, how to use designers, how to do ortho-resto, how to do 3D printing, all these things that I think a lot of the other courses fail. They're typically either my colleagues who teach Invisalign, they're focused on the ClinCheck, ortho only. The guys I know from Coist or Spear are focused on mostly on the restorative, and some of them are way behind in digital. I'm going to be the first one that puts everything in perspective for those doctors that are a little bit of a hand holding to go through the process.
So a comprehensive approach, just like your practice then.
Correct. I get some of these patients to go to the insurance doctors, and I said, they're so busy trying to diagnose treatment caries that they're missing stuff right in front of them that they should be seeing and recommending and explaining. And not everybody's going to go through it, but that's the beauty of it. You only need a certain amount to say, 35% increase in acceptance rate. What would that do to a practice? It would be amazing.
Absolutely. You're pulling more out of the existing patients. And it's not as though you were just trying to extrapolate more money from them. You're genuinely giving them better care because of it, right?
Okay. Some of these undersized laterals will do direct bonding, or somebody that's gotten chipped incisors will give them enough overjet. We'll get the bite. We'll do bonding, direct bonding. It holds up really well. So we have a lot of choices today. We can do direct bonding. We can do injectable bonding technique, and we can do print veneers. They're all they're more affordable and often less invasive than doing ceramics.
That's fantastic. Now, I heard you mention the Midas system before. Is that something that you've incorporated in your practice?
It's on my list. My wife always gives me a checklist of what I could spend in a year, but that's certainly the next purchase for me is to doing some of the Midas stuff, because the turnaround time. The one thing that I want to explain to people out there is that milling is typically 1 unit at a time. You can print up to 9 units on a Midas. You can print a full arch with a regular printer. Which, if we have time, I'd like to show the next case that I brought in.
Yeah, absolutely. What would you like to look at?
We actually is one of the first cases I did Illumina. So let me tell you about this patient. She came into my office 2017. One of the smartest things I think I did. Some doctors are great. They've taken courses to their own implants. Some have made their whole practice. I took a different turn. I brought in a board certified surgeon about 15 years ago. Right out of his program, we kind of hit together, we meshed, and we both really were very influencing of each other's career. So this was the x-rays that came in, and this is our first patient. She's, I think, 67 at the time, and she has a whole bunch of upper endos that are failing. She wants a nice smile. So she came in with that. She wanted to know what the options are. Looking back and forth, the lower posterior mandible, the bone is very thin, and she did have a bit of a budget. So we decided back at that time, 2017, to do an upper and lower, extract everything. She went into dentures for 3 or 4 months, and this became a locator case. And we opened the vertical up, which will show you that. And so this is the original. You could do this on all your photos, looking at the 1/3 of the face. There are instruments to show that. I'm also showing the profile. Her lower jaw is sagged in because she's overclosed. Her upper jaw is out slightly. That's our rickets line. So really quick way to make a diagnosis. It doesn't happen if you don't take photos.
And what program did you use to mock this up with these line references?
This was just a Photoshop lines on photos. Nothing. This is 2 Calvin standing. Okay, that was her intraoral. So you can see she's missing a lot of bone on the lower cage.
Yeah.
This was a precision. I love these precision partials that nobody wears. She wants the partial. That was the dentistry splint everything. This is the 70s, 80s cases, how we used to do things back then.
Yeah, you can see all the PFM work there.
Exactly,
Sure.
exactly. Okay, let's go to the next one. Okay, so this is afterwards, and we'll compare.
Wow.
We open it. Look, she looks younger, right?
She does. That took 10 years off her. And speaking of Dr. Debbie, you practice with your wife, correct?
Yes. We're one of the only couples that practice, and we share a desk in a 1,500 square foot office. Implant was
Wow.
41 years and married 41 years.
You must work very closely together.
We do.
Literally.
Literally, physically. She is the ambassador of the practice. She will give that comfort to patients. She'll listen. She's a much better listener than I am, and she could convince patients to trust us. Really, really good. Okay, look at the profile, right? How she's increased better, right? And so she looks better. She looks younger. So she disappeared from me for, I think, 7 years. Didn't hear from her. Came back. And then she comes back to me with the next slide. And so she broke off her, one of the central incisors broke off, which she crazy glued, and the flange broke. And she has an
Crazy for
overdenture
you.
case. Yeah. Crazy cool, right? So she convinces me to, she want to know the options. Can I convert this to a true fixed on case? So we looked at the case, we brought everything up, we took all our data, including our CBTs, because we had to convert the locators to multi-units, and we needed to decide what the angulation did, and we were able to use straight multi-units. So from that, Lumina is released, and now we're able to do our first full arch case with the help of Josh Jackson and Evolution Science using the Easy Refs. So let me show you that quickly. Next slide. And here is the iTero scans. Now, first time I did this, I would probably do something a little different, a little longer arms. You want to overlap them. They're made out of zirconium. They're very easy to scan. They're autoclavable. So this was done in a very early version of Illumina. And from that, the PMAs were made, went in. Let me show you how they fit. Using the exocad, we took her original design and we modified it slowly. This is an all-on-X case that we did today. And now that's her 3D printed. Everything was perfect. You could see on the left side, the bite is slightly open. And now she wears that, make any facial changes. We scanned that in the mouth. And after about another 4 weeks, we finished the final zirconium. Let's go show that. That's her final zirconium 8 weeks later. We used a bar on the lower because there's a bit of a cantilever. On the upper is all zirconium with Powerball screws. And let's look at her photos. That's her final restoration. Look how great she looks younger now than she did in the second stage with the overdenture. She looks even better. That's what it looks like in the mouth. Look at the occlusion, the access. That's what it looks like. The x-rays is a bit of a cantilever on it. She's been fine with it. Here we are. Okay. So that's her original. That's her finished with the fixed hybrid all on X restorations.
Absolutely. And you can see it really changed the shape of her face in a positive manner. And you can, the progress from the original photo all the way through the all on X is incredible. Any final thoughts?
Listen, go digital. Before we plan, we must digitally scan.
Excellent. I love it. It rhymes. It's beautiful. Dr. Glassman, thank you so much for your time.
My pleasure. Take care now.
You as well. Thank you for joining us for this episode of the Evolution of Dental podcast, brought to you by Evolution Dental Science. These podcasts are available on YouTube, Spotify, Apple Podcasts, and of course, your favorite platform. Please don't forget to like, subscribe, and share this video with all of your dentists and dental technician friends. We look forward to seeing you on the next one.